So in this discussion, we're going to look at various pulmonary disorders and conditions and talk about the fitness, exercise recommendations that we could have for individuals with these various pathologies. So looking at exercise and lung disease, so again, we all know by now a lot of the benefits of exercise. However, in individuals with lung disease, exercise might not always be beneficial. In other words, there's a lot of things that with exercise that could possibly bring along a lot of the manifestations for a lot of these and bring along various symptoms for a lot of these diseases. So again, the prime example of that would be, again, if you have someone with asthma or exercise induced bronchoconstriction, exercise can contribute to that. And again, exposure to air pollution can also bring on a lot of the things associated with asthma and chronic obstructive pulmonary disease. So again, if they're doing physical activity outside and there's any level of pollution in the air, that could actually contribute to symptoms coming along. So we have to kind of look at, one, obviously getting whatever the condition it is managed, and then kind of being able to work around it. Obviously, we're trying to apply exercise and physical activities for these individuals, but we have to make sure that we're obviously not, making the condition worse, and finding ways that we can manage it and continue to have them have these individuals be active. So if we look at asthma, again, asthma is a very common condition that we see in a lot of individuals. So asthma is a chronic inflammatory lung disease. So we're actually going to talk about the difference between asthma and exercise-induced bronchospasm, which many times both of those things will be occurring at the same time. But when we're actually talking about a diagnosis of asthma, asthma is actually an inflammatory condition, whereas exercise-induced bronchoconstriction by itself doesn't have an inflammatory component. So, and as we all know, the primary symptom that people with asthma complain about is the difficulty breathing due to the narrowing of the airways when someone has, again, an asthma attack. Now, interestingly enough, death from asthma attack is not a very common thing, but exercise does cause a bronchoconstricting response in a lot of asthmatics. So again, we're going to kind of talk briefly about why this happens, and then discuss, again, some of the management. Again, as always, we're going to look at a lot of the medications that individuals will use to treat and control this condition. Again, just looking at some various other things, and again, look at some of the precipitating causes of asthma. Again, we've seen the incidence of asthma go up again there's various theories and things that have contributed to this. Again, some of the things are up here on the screen. Again, is that, the increase in airborne pollutants, high ozone levels, changes in bacterial and viral infections. Again, these infections are always kind of changing over time and mutating. Does diet have anything to do with it? Possible reduced microbial exposure during infancy. So there are a lot of different variables here that could possibly be contributing to that. And again, we look at the impact of socioeconomic status. Again, the asthma severity and related mortality is twice as common in individuals with low socioeconomic status. However, the prevalence of asthma is greater among those with high socioeconomic status. So it's kind of an interesting point there to keep in mind. So again, just kind of giving some of the background on the condition and some of the different ways it affects people. So again, asthma here, again, it's bronchial inflammation that involves, again, a lot of different blood cell types. So your mast cells, which are cells in our connective tissue and tissues throughout the body, your eosinophils, T lymphocytes, macrophages, neutrophils, those are all different types of white blood cells. And then the epithelial cells that kind of line the tissues in the body, they're all involved with this inflammation process. And again, you get those symptoms of, again, what you get with the asthma attack: wheezing, breathlessness, chest tightness, and coughing. And I'll show on the next slide the result. So the issue is you want to get this inflammation under control, because as attacks happen and that inflammation tends to persist, you do start to get some remodeling in the airways and some further constriction that just naturally happens to the actual airways. So as you look at this picture, you could see again here obviously is your normal airway, your bronchioles. Over here you can see the smooth. They're showing all the various events that are going to happen in an individual that has asthma. So you can see the mucus formation, the inflamed airway, which then causes a narrowing, and again, the chronic inflammation over time becomes more of a problem. So you really want to make sure that that gets managed so you don't end up having this remodeling of the airway that's going to make breathing more and more difficult as time progresses. Again, you can see they're kind of showing the inflamed wall of the bronchiole. So again, if you go back to think about just the anatomy of the lungs, the bronchi and the bronchioles kind of leading to the alveoli, which you can actually see in this picture. This is representative of an alveoli down here where the oxygen and carbon dioxide exchange takes place. But this is just to kind of show you what is actually going on in an individual that has asthma. So as far as, categorizing asthma and looking at it, so again, the criteria for defining asthma and the severity is in Table 5.1. Basically, you have 4 different categories of asthma. You have intermittent, you have mild persistent, you have moderate persistent, and severe persistent. And basically the way it gets categorized, and look at the table so you can kind of see, I want you to be able to at least have an idea of the different ways we kind of look at it. So basically you look at the number of days with symptoms. Do they wake up at night with issues? You look at the actual lung function, okay? So the forced expiratory volume is another way that this gets classified. And then, how often does it interfere with activity? And then how often do you have to use medication to control it? More specifically, again, what we call the short-acting medications, or what are known as the beta-2 agonists, which is the rescue inhaler that asthmatics will be using when they're in the middle of an acute attack. So we'll talk about the different types of medications, but that's probably the most common one people think about because that's what we see a lot of individuals using, particularly during physical activity when they start to have difficulty. And again, as I said, I went through the categories, but again, the severity is going to range from intermittent, which is the lowest, so that's the number, with the fewest number of days per week with symptoms, the fewest number of times waking up at night. The lung function's not quite as bad, and then again, not a whole lot of interference with normal daily activities. So again, but look at that table so you could kind of see. Again, and another thing to note is look at the measurements, particularly for lung function. So here, I kind of highlighted on the slide the forced expiratory volume. You also have forced vital capacity and what's called peak expiratory flow. Those are also things that kind of get measured and used to kind of test function. So be aware of those measurements as well. So again, I brought this up already, but the category of exercise-induced bronchoconstriction or exercise-induced bronchospasm, you may hear me utilize both terms interchangeably as I'm discussing this. But the exercise-induced bronchoconstriction is actually defined as a transient narrowing of the airways during or after the cessation of exercise, and it can occur in those with an apparent asthma and those without. So in other words, this can actually occur by itself. So an individual that would just have exercise-induced bronchoconstriction, what they're basically getting is a response to their airway to exercise. And we'll talk about kind of the mechanism that occurs with that. And it's different from asthma in that you don't have the inflammation associated with it. Now, many individuals with asthma where the inflammation is present also have exercise-induced bronchoconstriction. So that's an important point to note. And again, here that gets defined as a decrease, and again, the forced expiratory volume of 10% or greater. And that may be the only symptom of asthma in some individuals. So again, when we're talking exercise-induced bronchospasm or bronchoconstriction, that's just the transient narrowing, again, directly related to exercise. And again, it can occur with someone who is diagnosed as having asthma with the inflammatory component and those without. So in further looking at this, exercise-induced bronchospasm, you have your prevalence. Again, you tend to see a higher percentage as far as the prevalence in the specific sport populations. And as far as kind of the cause, the pathophysiology, the mechanism, if you will, as to how this occurs. So there's the water loss theory, and then there's also a temperature exchange theory that we look at. Really, they both kind of result in the same thing. So typically what you see is water loss from the airway surfaces. So again, part of your airway's responsibility is to humidify the air as it's coming in, and it's believed that due to the water loss from the surfaces of the airway kind of causes this kind of rebound circulation effect to the airway, which causes the constriction. That it could also be attributed to temperature as well. So temperature kind of has the same effect. Part of the responsibility of the airway is to warm the air. In the case of cold air in particular coming in, the heat given off from the airway basically causes the same thing. You get the rebound circulation and then the constriction. They also believe that allergens and airborne pollutants can also precipitate the bronchoconstriction as well. And again, this kind of brings us to, so in looking at kind of like the water loss theory or the temperature, the idea behind temperature. So it's mistaken a lot of times. People tend to think that, you know, it's heat and humidity. It's actually most prevalent in cold, dry environments. They also believe that it can happen inside and with indoor pools, due to the trichloramine levels in the pool that can kind of irritate the airway as well. So again, it's very common. You hear it a lot. They say, well, it's hot and humid out, you know, someone with exercise-induced bronchospasm. It's actually the opposite. Cold, dry air tends to be many times the precipitating factor. So as far as treatment, again, therapy is going to really be individualized, like with a lot of different things. Again, it's going to kind of depend upon, you know, how well the person is kind of managing their symptoms in general. So again, the individualized therapy is going to be the key to successful treatment of asthma. Again, medical intervention can control the respiratory symptoms and offset lung function decline over time. So we're looking to minimize the number of symptoms and the long-term effects of, you know, repeated episodes of the inflammation and everything that occurs with asthma. So again, the optimal treatment, we're looking at the elimination or reduction in airway inflammation, exacerbations, and we're trying to minimize the use of rescue inhalers. Because again, that's showing that, you know, every time there's an asthma attack, that inflammation, if it's present and the person's been diagnosed with asthma, that could be causing long-term problems. So we're basically going to have two classifications of medications. Again, make sure to kind of take a look at those on that table. You're going to have controllers to reduce the inflammation long-term. Those are usually going to be taken on a daily basis. And then you have the relievers or the emergency inhalers that people take to counteract acute obstruction and bronchoconstriction. And those will supplement the use of the controllers, and those are going to be taken as needed. So you have the long-term treatment-based anti-inflammatories, and you have the what we would call the rescue inhalers that individuals take in acute situations. So here you have, again, just as we talked about, the inhaled corticosteroids. Those are taken over a long period of time. They tend to have fewer adverse effects than oral corticosteroids. So inhaled corticosteroids won't have as many systemic effects typically that you tend to find with oral corticosteroid use. And again, these can help improve the pulmonary function, reduce inflammation. If taken for more than 3 weeks, their effects are somewhat diminished. So again, This will be something that will be monitored by the physician in looking at the overall treatment effects that are going on therapeutically for the individual. So looking at other medications, some other things, another long-term type treatment is with something called leukotriene modifiers. This is another medication similar to the inhaled corticosteroids that will look for more, kind of long-term benefit. Now, leukotrienes are chemicals that your body releases during inflammatory responses, and as well as when, for instance, you expose yourself to something you're allergic to, and it kind of produces a lot of the same symptoms that someone complains about when they have an asthma attack. Now, interestingly enough, the effectiveness, there's a large range of effectiveness for individuals with this type of medication. So these could provide literally no benefit to somebody with asthma to giving very complete symptom relief. So it kind of depends upon the individual's physiology as far as like how asthma is affecting them individually. Then you have your beta adrenergic agonists. Again, these are your bronchodilators that are used in both prophylaxis and rescue from acute asthma exacerbations. So you have your two different types. You have your short-acting beta agonists and your long-acting beta agonists. Again, your short-acting beta agonists are going to be used particularly when you have your acute attacks. They tend to peak after 60 minutes. Again, common recommendations are going to be about 1 inhaler a month as far as the maximal dosage. And again, if someone's using these daily, that shows a need for improved asthma control. So again, if someone's having to use the short-acting beta agonist very frequently, we're looking at, possibly having to change their therapeutic regimen as far as to kind of control the asthma a little bit better. Long-acting beta agonists function similarly to the short-acting beta agonists, but they also help in reducing the frequency and intensity of asthma episodes and exercise-induced bronchospasm episodes. The effects from these do last a little bit longer, but however, these are also not recommended to be considered a standalone medication and should be used in conjunction typically with some type of inhaled corticosteroid. So again, take a look at the medication chart just to kind of get some other details as far as these medications are concerned. But again, be aware of the different classifications and kind of their mechanism as far as how they help. And again, it'll typically be some combination of medications that will get prescribed for individuals with asthma. So in looking at the effects of exercise on asthma patients, and there's quite a range of effects here that we're going to look at regarding the intensity of the exercise, the duration of exercise. So again, first to note, again, there does seem to be a greater prevalence of exercise-induced bronchospasm in typically athletes that are in cold environments, cross-country skiers, ice rink athletes, swimmers because of the chemicals that are in the pool. And then again, we also just look at just in general outdoors. We talked about some of the precipitating factors with that. If exercise-induced bronchospasm does occur, it can occur during exercise or immediately thereafter. And a lot of that depends on the intensity of the exercise. So what we do tend to find is that lung function generally gradually falls during longer-term aerobic exercise. And a lot of times it depends on the intensity as well. If you look, typically during the light intensity periods, say like an interval training program, is where lung function actually starts to decline. So usually during the higher intensity bouts, lung function tends to stay a little bit higher, and then during the lighter intensity bouts or during the recovery bouts is when you tend to see issues. So many times what they tend to see is that it's usually many times actually following exercise is where a lot of those bronchoconstrictive influences kind of start to create issues as far as the difficulty with breathing. So again, it does kind of vary based upon the exercise that they have. They do recommend what they call a bronchial challenge test prior to beginning an exercise program, which will kind of alert the exercise professional to the intensity of the condition, along with the duration and the mode that will kind of trigger an attack. Many times clients will use a short-acting beta adrenergic agonist prior to exercise, which can decrease the likelihood of an attack. And one of the guidelines is to make sure to do a really good warm-up prior to exercise, because basically it could create what's called a refractory period. So when someone has exercise-induced bronchospasm, if they do a 10 to 15 minute warm-up that uses variable intensities, it could actually put their body through a refractory period where they can't suffer a bronchoconstrictive episode. So that's something that could also kind of be included in the protocol for the individual, in addition to possibly using the short-acting beta adrenergic agonist if needed. So, and again, as far as like during exercise or when the episodes tend to occur, again, it appears that with research, it's kind of the type of exercise, the intensity, and the duration determines whether bronchoconstriction will occur during the exercise, at the end of exercise, or not at all, as far as if an attack would occur. As far as the exercise recommendations, again, you could review the tables for this. Just some general things that I'll note here. Aerobic intensity should start out lower and just progress to slowly avoid symptoms. So again, we're talking intensities about 40% to less than 60% of VO2. Of VO2. Again, you could also look at heart rate reserve for that, and then just continue for 20 to 60 minutes, 3 to 5 times a week. Vigorous intensity is acceptable to do as long as symptoms don't get exacerbated. And again, the resistance training could kind of follow many of the general guidelines. If you look at the resistance training guidelines for somebody, again, they fall in that moderate range of about 60 to 80% with the 6 to 12 repetitions. Again, that's kind of a good starting point for most individuals. So our next condition we're going to look at is pulmonary hypertension. So pulmonary hypertension is both a hemodynamic and pathophysiological condition where the mean pulmonary arterial pressure is greater than 25 millimeters of mercury at rest. There's various pathophysiological mechanisms that are involved with pulmonary hypertension. Basically, it depends upon the type that the person has. There's 6 different categories of pulmonary hypertension that all kind of represent various pathophysiological mechanisms. So the management for an individual with a diagnosis of pulmonary hypertension does not involve a general protocol. You have to consider the type that they have and kind of some of the underlying factors. Pulmonary arterial hypertension is a specific clinical condition characterized by pulmonary arterial hypertension in the absence of other causes of precapillary hypertension. So there's various underlying origins to this. It could be caused by drug toxicity. It could be idiopathic, meaning it doesn't have a known cause. It could be hereditary. All causes of pulmonary arterial hypertension produce similar changes in the cardiopulmonary system. This particular type is rare. However, it does have a substantial economic impact due to the effects that it has on the patients that have the pulmonary arterial hypertension. The general condition of pulmonary hypertension is not uncommon. Many individuals have it. It's typically going to be associated with other types of chronic cardiopulmonary diseases that include COPD, or chronic obstructive pulmonary disease, and diffuse parenchymal lung diseases. So with pulmonary hypertension, one of the things you have to, again, see with this is that, again, typically this is going to be associated with other, chronic cardiopulmonary or infectious diseases. So that's something that, you're going to see very commonly with this. Again, COPD is another thing that would predispose somebody to this, as would any type of diffuse parenchymal lung disease would also function with that as well. So the thing to understand about, in general, when we talk about the circulatory system as it relates to the pulmonary system, is that the pulmonary circulatory system is a high flow, low pressure, low resistance system relative to the rest of the circulation. In other words, when you look at the circulation to the pulmonary system, it has a much higher blood flow and a much lower pressure relative to the other areas of the body. So, for instance, the resting peak systolic blood pressure in the pulmonary system is less than 25 millimeters of mercury. The diastolic's less than 10. So the pulmonary arterial pressure is somewhere around 14 millimeters of mercury. And then any increases in the blood pressure is going to be related to an increase in cardiac output or an increase in vascular resistance, which ends up kind of being the causative mechanism in pulmonary hypertension. In other words, pulmonary hypertension is typically caused by resistance within the vasculature inside the pulmonary system, which again tends to be a very low resistance system. So as we said, a variety of events result in pulmonary hypertension. Again, primary vasoconstriction, parasitic infections, or hypoxia-induced vasoconstriction. So under hypoxic conditions for the pulmonary system, or anything that would cause reduced oxygen, your pulmonary arterial smooth muscle is going to contract. So that's going to cause the arteries to constrict. And then that will normally promote a ventilation perfusion matching. In other words, it'll kind of allow the person then to change the hypoxic situation. However, in any type of chronic hypoxic lung disease, that increased pulmonary vascular resistance resulting from the vasoconstriction is going to result in pulmonary hypertension. And then you have, again, pulmonary hypertension can lead to other systemic issues. So, for instance, right-sided heart failure, liver dysfunction, and then just pulmonary or system-wide edema. So, and again, when you look at your book, kind of describes the right-sided heart failure mechanism and why that happens. But again, essentially, if the vascular resistance in the pulmonary system is going to increase, in the example of the right-sided heart failure, and again, you may have to go back and review. We talked about how the blood flow goes through the heart and the circulation immediate to the heart. When you get that increased vascular resistance, you can get that increased pressure. The right ventricle has to work a lot harder, which will then cause this overload and then subsequent dilation, which will in the end result in right-sided heart failure. So that basically means that the blood's going to pool in the right side of the heart. You're going to get vascular congestion in the vena cava, and that's going to affect the circulation in general and start to cause edema to form. So other things we look at with pulmonary hypertension, so again, it's going to lead to respiratory muscle weakness and dyspnea during exercise. You're also going to have very limited exercise capacity, particularly with pulmonary arterial hypertension. And again, that's going to negatively influence the quality of life. Your signs and symptoms, again, are generally non-specific. So again, dyspnea, fatigue, syncope, angina, various heart murmurs. So again, obviously the heart's going to be affected. The cardiovascular and the pulmonary system obviously have a very close connection, and just based on your previous classes, again, you kind of get how they both kind of function together, again, in sustaining life. So again, it's going to have various repercussions on the cardiovascular system and kind of what that means as far as the overall function. So again, it's a bunch of different reasons. One as to why this condition does occur. I mean, we do have a general pathology of the condition, but there's various things that could lead up to it. So again, and having a good understanding of how the cardiovascular system and the pulmonary system work together allows that to be seen a little more readily. So regarding medications, so again, the thing to consider is that, individuals that have pulmonary arterial hypertension and pulmonary hypertension may have different pathophysiologies causing the condition, and they may not necessarily use the same medications. And many times, any comorbidities will determine the approach with medication. Okay, and again, it's not going to be your responsibility to know every single medication and how it would be prescribed, because that's not the role. I'm more concerned that you just, in general, can recognize the medications used to treat, and that you kind of know, obviously, knowing their effects and side effects are going to be important relative to exercise. So again, that's kind of what we're looking at here. Again, medication for pulmonary hypertension is used to improve function and delay the progression of the disease, and possibly more invasive procedures such as a lung an individual could potentially end up needing a lung transplant. Again, the idea is to kind of delay that, or make sure that it doesn't occur. So for vasoreactive pulmonary arterial hypertension sufferers, many times calcium channel blockers will be used because they're effective at dilating the vessels. So calcium channel blockers are something used for people that just have, kind of general primary or secondary hypertension. The presence of tachycardia or bradycardia will determine which one is prescribed. For non-responders to calcium channel blockers, more specific medications are used depending on the signaling pathway that results in the symptoms. So again, it's kind of to figure out, well, why do they have the pulmonary hypertension? And then from there, if you look at the list of medications, so again, make sure you review your medication list. They'll look at that. So again, when treating somebody with some types of pulmonary hypertension, some pulmonary arterial hypertension medications may be useful, particularly if it's caused by left side heart disease. Those with lung disease or hypoxia, may not be responsive or may suffer ill effects from that. Again, currently the use of other drugs such as anticoagulants, anti-arrhythmics, diuretics, ACE inhibitors, and beta blockers are currently being looked at as well. So again, look at those other medications, again, be able to recognize them as being possible treatments for pulmonary hypertension and pulmonary arterial hypertension. Again, get an idea of their effects and side effects. So in looking at the effects of exercise, again, because the pulmonary system is low pressure and has little ability to reduce resistance, increased cardiac output is accommodated by recruitment of additional blood vessels in the pulmonary system. So in other words, when you're looking at exercise in a healthy person, this mechanism is in place to kind of accommodate for the increased cardiac output. So as your cardiac output is going up, as it would with any type of exercise in a healthy person, there you get additional blood vessels within the pulmonary system to kind of prevent any major increase in the resistance. And again, because you essentially don't want to, because again, the pulmonary system doesn't have the ability to accommodate with that. Now, in the situation of somebody with pulmonary hypertension, that accommodation is not as effective at preventing a rise in pulmonary arterial pressure. So in other words, in individuals that have pulmonary hypertension, they're going to end up getting, because of exercise, the hypertension is going to be kind of exacerbated. So that's something that you're going to have to be mindful of in individuals who have this, and again, kind of in conjunction with how they're responding to a lot of the early exercise, you have to be mindful of that. So because of this, again, exercise testing for these individuals is going to be very important. And many times exercise testing is useful in actually identifying early stages of pulmonary hypertension. So again, it could reveal a lot of subclinical impairments, for instance, in the right ventricle of the heart. So many times individuals will get actually diagnosed with pulmonary hypertension, as a result of exercise testing, if it gets done, because they're kind of reporting some of the symptoms. But to note, so again, exercise, however, does improve symptoms and capacity and activities of daily living. So again, there are going to be benefits of exercise. The key is, again, going with the early recommendations to get their body to adapt and make sure that they don't end up causing more damage because maybe the exercise is of the wrong intensity or the wrong progression. So in classifying pulmonary hypertension, again, in looking at exercise pulmonary hypertension, so previously a mean pulmonary arterial pressure over 30 millimeters of mercury was considered exercise pulmonary hypertension. So in other words, with exercise testing, if someone had that, they were considered to have exercise pulmonary hypertension. So, however, they kind of looked at a different way of diagnosing that. So more recent standards include just a general pulmonary resistance of greater than 3 millimeters of mercury per liter per minute, since rising pulmonary arterial pressure is normal in healthy individuals. So in other words, this just made it a little more sensitive and specific to kind of discriminate between individuals that were just getting kind of the normal rise in pressures that would still occur versus individuals who are actually having exercise pulmonary hypertension or would be on their way to just, kind of general pulmonary hypertension. So again, exercise testing can be used to help determine the severity of both pulmonary hypertension and pulmonary arterial hypertension. And then here we're just showing some other measures, a VO2 peak of less than 10.4 milliliters per kilogram per minute, or the inability of systolic pressure to rise above 120 millimeters of mercury is associated with a poor prognosis. So again, these testing measures kind of let individuals know sort of where they're at and what are some of the concerns that are going to have to be with an individual who is going to undertake a fitness regimen. So as far as exercise recommendations, there's going to be some things here that we see that we really haven't seen with some of the other conditions. So the most common protocol following diagnosis involves 3 weeks of in-hospital training followed by 12 weeks of in-home training. So in other words, again, a condition like this, we're going to be looking at being much less aggressive than we would even think to be with some of the others, just due to the pathology associated with it. So an initial 3 weeks allows individuals to become familiar with correct exercise technique, learn how to gauge intensity, because again, we don't want them, due to already having the pulmonary hypertension, to be doing too high of an intensity that would cause possible further damage to both the pulmonary or the cardiovascular system for that matter. And it'll include some educational components regarding the importance of adhering to the program. So again, we want these individuals to be active. We know that exercise will improve symptoms in this, but now we look at, as far as the intensity component to it, particularly for the cardiorespiratory exercise, to make sure that it's of an appropriate intensity and that they're progressed accordingly. So they'll be medically supervised typically for the first part of this, and then again, gradual progression throughout the early phases of their exercise. So I'm kind of looking at some general recommendations. So again, some studies have used short intervals alternating between low and higher. And higher here, we're looking at 60 to 80% of max heart rate, but there's not enough studies to recommend a particular training protocol. So in general, pulmonary hypertension clients should be physically active within tolerance of their symptoms, but perform a kind of a combination of light to moderate intensity workloads. Looking at specific respiratory muscle training, that would be very important, because we know that some weaknesses are sort of noted there with the respiratory muscles, and obviously including resistance training as well. There'd be further things we'd want to look at. We'd want to be careful with both high intensity aerobic or resistance training, because that could exacerbate their symptoms, or could also elicit Valsalva maneuver, which in the case of these individuals, we all know what Valsalva maneuver is. You'd want to really watch that with the resistance training, because again, that could create further stress to the symptom by raising pressures. So that would be something to note as well. So again, these programs are typically aimed at just improving physical function and quality of life. Um, Again, they should at least initially undergo a medically supervised testing to determine what their symptom threshold is. So that will be very helpful in creating a program. So if an individual is interested in physical exercise, they should undergo the medical testing, because that will kind of tell them and give some feedback as far as what's the intensity that they can tolerate, and then the fitness professional could then kind of base the intensities off of that.